work with us in terms of survivors and survivor programs. So before I start, I'm just going to ask very quickly, how many of you here are survivors? Show of hands, please. Wonderful, great. Okay, another show of hands. How many of you here have been on immunotherapy, hormonal therapy, or targeted therapy? Wonderful. Another show of hands. How many of you here spend more than 20K per cycle for your therapy? 20K per cycle? More than that? 25K per cycle. Okay. How many cycles? Many cycles. Too many to count. Okay. Okay, so that's what I'm going to be talking about today. Okay. So basically, in NCSM, we sat down and we saw what is the need at the moment for patients. Okay. And we felt that there was a very big gap between patient affordability and the drugs that are being used in the market today for targeted therapy, hormonal therapy, and immunotherapy. So, when we researched and we did the market survey and all these things, we said, okay, this is a gap that we have identified. How can we try and solve or get past this gap? Okay. Now, if for those who did not take these modalities of treatment, those who were only on chemo and radio, conventional therapy. Just for your information, one time of targeted or one cycle of targeted hormonal or immunotherapy can go up to 25K or sometimes even 30K per cycle. So imagine doing this on a 3-weekly basis. You got money? No, right? I also no money. Okay? So if you do this on a 3-weekly basis, you're spending almost 25K on a 3-weekly basis. Sometimes some patients come to us and they say, I might as well just die. Forgive me for being very straightforward. But yes, that's what they say. Right? I might as well just die. Baik, saya mati saja. Right? Some people choose not to take the therapy or not to take the treatment because they think the money can be used for my family. Right? After I pass away, my family can be happy. Correct? Okay. So, when we were discussing, and then we realized, oh, there is a treatment or rather assessment that is being done overseas, right? We looked at the overseas countries because Malaysia is very far back in terms of financial aid for patients with cancer. Okay? So when we looked at it, we realized that we can actually try and duplicate or replicate this program to Malaysia, right? But when we looked at the questions in the program that was used overseas, we realized that none of it is pertaining to what Malaysia is. It's not culturally sensitive or significant. Okay? For example, the questions there were asking, what kind of flooring do you have in your house? This is one of the questions that they ask. What kind of flooring do you have in your house? If I ask in Malaysia, the fellow will look at me. Why does it matter? Right? Why does it matter if I have tile flooring, wood flooring, parquet flooring, how does it matter? It makes no difference. Okay? You can be in Bangsa, you can stay in the biggest house, but you still have parquet flooring because your house is that old. Doesn't mean you don't have the money or the funds to afford your treatment. Correct? So we took a good look at this. And we realized that we need to implement it for Malaysian context. Okay? So what did we do? We developed an assessment which we call the CAN Assist. It's called the CAN Assist, and it is an assessment that is developed by National Cancer Society Malaysia, particularly me, a few colleagues, and Dr. Murali. Okay? Now, why is it called CAN Assist? Anybody can tell me? Yes, because you can assist and you assisting for cancer treatment, right? It's a play on words. Thank you. Yes. Okay, so what is it? It's a means testing tool or an assessment tool that we have come up with to help patients who are in need of financial aid or enhanced support to afford their cancer treatment. Okay? Thank you. No? It's not on? No? Okay, got it. Yes, okay. So, a little bit of background. What is means testing? Means testing is a tool, is a systematic assessment mechanism that evaluates a patient's financial circumstances. So what does this mean? Basically, it's a fancy way of saying that we ask you for all your documents, we look at what your financial status is. Okay? And the primary purpose of this tool is to assist in assessing the financial capabilities of cancer patients, and by doing so, we aim to identify those eligible for enhanced support, which includes schemes for targeted hormonal and immunotherapy treatment. Okay, so again, just very high-flying words to say that we look at your financial status after or before you have started your treatment for targeted immuno or hormonal therapy, and we try and see if you are able to afford the treatment or not. Okay, if you are not, then we will tell your medication provider or your doctor, we will tell them, look, this patient is not able to afford, how can we help? Or how can you help? Okay? Now, who can come for this eligibility criteria? Who can come for this assessment with us? Anybody, basically. As long as you are a Malaysian citizen or a Malaysian permanent resident, or foreign nationals with valid employment pass or long-term visa, 18 years old and above. Okay, so we do for anybody who has valid documents in Malaysia and who are 18 years and above. Okay, what are the documentations required for Malaysians? You of course have to give your IC number, your pay slip. Sorry, am I blocking? Your IC number, your IC, your payslip, your EPF statements, bank statements from the last 3 months, proof of employment, utility bills, past medical treatment receipts, insurance statements, vehicle ownership, land or house ownership, welfare card. You might be thinking, wow, I applied for loan also, not this many documents. Right? But the reason why is because we want to make sure that those who really need it get the aid that they need. Okay? I kid you not, we have people who are applying who get almost their EPF account got almost 2 million in savings, and then their monthly pay, their pay slip is about 20k a month. They're still applying. And then when you reject, when you say, oh, you're not allowed to, you're not eligible, we found you not eligible, they'll go and complain. Go complain to the doctor. What doctor? So we still got people. So we need to make sure. Why we ask these many things is because we want to be thorough in our assessment, and we want to make sure that the right people get the right help that they need. Okay? Now, when we say patient and their spouse to submit, this is because we want to make sure that we take the household income. Okay, so when we say household income, everything also will be household. So household income, household expenditure, household debt. Okay, the EPF statement also, we see if both of you are, both the patient and the spouse are earning, we see the combined amount. That's the amount that we take. Okay, don't worry, we also have measures in place. If you are less than 50, we only take for account 2. If you're more than 60, we take the whole thing. We have all those measures in place. Okay? If you are a foreign national, everything else is the same. The only added thing is you need to valid evidence of right to stay in Malaysia. Okay? So, some people will ask me a question, what if I am a Malaysian citizen and my partner is not? Same thing lah, just give me your IC. For you will be your IC, and for your partner will be passport with valid right to stay in Malaysia. Okay? Now, what do we assess? We go based on the 3 pillars of income and assets, expenditure and debt, and cancer-related health expenditure. This is where we believe that this means testing tool is different. Because many means testing tools out there. They just take, or when they ask for financial aid, they just take the blanket statement of income versus debt. Okay? Or income versus expenditure. But what we are trying to see is, yes, you might be having a very high income, or you might be having an average income, which puts you at the M40 group, right? But even if you are at the M40 group, number one is you don't get all of the benefits that the B40 group gets, okay? All the whatnot lah, Peka B40 lah, what lah, all that, right? But some, or most of the time, what we see is the M40 group, they are disadvantaged because as a result of their cancer expenditure or cancer related expenditure, they are now in the B40 bracket. But that is not being captured in Malaysian statistics, right? So even if you are M40, you cannot apply for all of these things. So that is why we added this part here that says cancer related health expenditure, and this part is the part that makes the most difference. Okay? So in income and asset, we of course take your monthly household income, and again, to localize it to Malaysian context, your assets include your EPF, your medical insurance, your house or land owned, your vehicle, and your jewellery. We added jewellery because we thought a lot of makcik will have jewellery, right? Keep in their bank, right? So we added jewellery, okay, as an asset, because as we know, when we were thinking about it, we thought, what is it that you could sell as an asset that will give you financial or monetary gain for you to pay for your treatment, right? Jewellery is one of it. When we look at your expenditure and debt, we look at the, of course, normal things, groceries, transport, and all that. And debt, we look at all of the loan repayments as well as your insurance payments. So these two is pretty standard. But this one, the cancer-related health expenditure, we not only look at your past expenditure to get a baseline of what you have spent before, what is the amount that you have spent prior to this treatment, but we also look at your current or projected health expenditure, which means how much are you going to possibly need to spend for, okay, let's say your doctor says you need 8 cycles of this particular drug, right? We will take one cycle, the cost of one cycle, we times it by 8. That is your current or projected health cancer-related expenditure. And that is the amount that we will use to consolidate your expenditure, this part lah, okay? So, when we do this cancer-related health expenditure, we find that it is indeed like what we thought. Many people are going into financial toxicity or financial ruin simply because of their cost of their treatment, right? And this is a very, very sad thing to say. Many people do the treatment, don't have enough money, stop the treatment. And then the cancer comes back even more aggressive than before, okay? So how do we assess? So you'll see, sorry, it's quite small. You will see the household income summary, household wealth summary, household expenses summary, debt summary, and the cancer-related health expenditure. So what we do is, we plus, minus, minus. Okay? Don't worry, the formula is, you don't need to worry, that's my problem. Okay? So we have a formula for calculation, and each question on the tool has 5 ranges given. For example, total household income. We start at, let's say, 0 to 100 is tier 1. Tier 2 will be 101 to 200, 201 to 300. Okay? So you have 5 tiers, 5 range. And then we see, based on your payslip, we look at it and we say, okay, you are now in tier 4, let's say 401 to 500. So then we will give you a score point. So each tier has a score point. If 0 to 100 is maybe 1 point, 101 to 200 is 2 point, let's say, okay? So we give you a score point. So when we finish with all of the answers, the cumulative score point is added up and the monthly differential is calculated using this formula, okay? And the patient's eligibility is then assessed based on a prior agreed cutoff. So what does this mean? This means that we work on the basis of vendors. Okay, and CSM is a third party administrator, or like they say, a TPA, right, for vendors who are wanting this means testing service. Okay, so they will give us a cutoff point, or we will agree upon a cutoff point together to say that this is the range that they are going to support, and this is the range that they believe they can offer the enhanced support for. So the range is not in our hands, it is in the vendor's hands. Okay, because they are the product expert. Yeah. So once we have added everything up and we've calculated the score point, if it is within the score point or the range given by the service provider or the vendor, then you are eligible. So then the process kicks off of us telling the vendor, this patient is eligible, please give them enhanced support. Yeah? Yeah. Okay, so I have reached the end of the presentation, but I'm sure if you have questions, please feel free to ask me. Yeah? Go ahead. Yes. Yes.
When I was looking through your checklist on your criteria, I think you don't put a criteria that if your treatment is in private hospital, you are not eligible. You must be in public. You didn't put it, so it's very lenient. How do you see from that aspect? Like Masala, you must have the treatment at a public hospital. You are in private hospital, it implies that your operability is sustainable to be public.
Okay, so the question was, why is there no distinction between public and private patients? Okay, so like I said earlier, madam, we have realized that patients, okay, number one misconception in healthcare is if you are in private, you can afford it. No, that's not true. Okay, and if you are in public, you cannot afford private healthcare. That's not true either. Public healthcare is open to all Malaysians. Okay, someone as rich as maybe a CEO of a company, he's also a Malaysian citizen, he wants to get public healthcare, he can always go and wait in line in HKL to get public healthcare. Correct? Nobody is going to say, no, you have money, you cannot come here. Nobody is going to say that, right? Correct? The same way, in private healthcare, nobody from the private is going to say, no, you don't have money, you cannot come here. Correct? They are just...
They always advise it's very expensive. You say,
yes.
It's a cost, then they advise you.
Yes, they do advise you. So certain places like UMMC and UMSC, they have that mechanism where if you are in the private sector, which is UMSC, they can refer you to the public sector, which is UMMC, right? But let's say you are in Gleneagles, Pantai, okay, these hospitals, let's say you are there. They don't have that mechanism, or rather they can do it, but they would rather keep you with them, right? It's an unfortunate truth. I'm sorry if there's any private hospital reps here today, but it's the unfortunate truth. They would rather keep you with them. So then they advise you, of course it's your choice if you want to stay or not, but that misconception of everybody who goes to private can afford it is something that we avoid as much as we can. Because patients who go to private, they might have their own reasons for going. Maybe it's close to their house. Maybe their children can only, afford a flexible schedule to bring them to hospitals and not the Monday to Friday schedule of public hospital, let's say. Many different criteria. Your socio-economic status determines a lot of things in your choice of hospital, right? So just because you're going to a private hospital, we cannot say, I'm going to punish you by not giving you any aid. We cannot say that. So when they apply, whether you're private or you're public, we accept. As long as if you are private and you are able to afford, you still won't meet the cutoff point. Because there's no score point for if you're from public or from private. It is wholly based on your finances and your financial situation. So that's why we don't discriminate like that. Yeah? Do you think that, sorry, hold on. Do you think that we should only do for public patients?
I think you need to have a further study of it, but generally speaking, from the point of patient, if I can afford, I definitely will choose private rather than public because of the waiting time or whatever. So by choosing that private, it's already give the stigma that you are not rich, but you are sustainable compared to the public. public will be the second choice, not the
Yep.
first choice. There is one point of view, but it will not reflect the general term.
Yes, I'm going to give you a fun statistic. Of the assessments that we have done to date, I think maybe roughly around 70% are private hospital patients. We have quite low public hospital side. Because in public hospital, most of the time, they can't even afford treatment. Like, let alone immunotherapy or hormonal therapy for 25 to 30K a month. So they just choose not to do it. The private side is the one that wants to fight for it. They fight. They reach a level where they cannot sustain. Then they come to us. So we see, that's what I'm trying to say. There's a lot of socioeconomic status or socioeconomic determinants that go into this only, besides your financial status. Yes, ma'am. Question? Oh, you took notes. Nice.
Just wondering, who are your service providers?
Who are my service providers? I unfortunately, due to privacy policies, I cannot divulge who our service providers are. Yeah.
So, by the look of your services provided for this, you mentioned you are a third-party administrator. So, are you functioning as similar to other third-party administrators from private healthcare industry?
Meaning? Are we audited? Is that what you're asking?
Not only that,
Yes.
I mean, in terms of as an administrator, do you be benefited by in any way by doing this?
Accredited in any way?
No, offering these sort of services, are you benefiting from?
Do you get commission?
Oh, do I get commission? Okay, no, we do not get paid on a commission basis. We only get sustained for the headcounts that we put into doing the assessments. So the remuneration is not on a commission basis. So we don't stand to gain anything.
So in terms of headcounts, you mentioned what do you mean by headcounts? Is it?
Because to run the assessment, we need people then. Because the assessment is fairly tedious, right? So we need actual human beings to carry out the assessment. It's not just like an Excel sheet or a program. It's actual human beings. You're calling, doing the assessment, talking to the patients and all those things. So that is what NCSM covers mostly, but we also get a little bit of a remuneration for that lah. But not on a commission basis.
I'm just wondering in terms of your operating costs, your overhead and all that, in order to provide these sort of services. So, are you doing it in terms of like community services or public services or your users and employees, and enough to cover your overhead?
Yes, so, okay. So we're getting very technical. Okay, operational cost wise, yes, we only, how do I, answer this? Okay, basically, we only have enough money or funding to cover our overheads. Okay, we don't get any amount of compensation for each assessment done or development of the tool or anything like that. That doesn't happen. Okay, we only have enough, even from our own operational costs also, we only have enough to cover the headcounts who are carrying out the assessments. So if you want to ask in terms of how are we doing this, it's like how most NGOs run lah. You get funding for the headcount and you carry out the program. That's all.
May I ask, in terms of the service providers, does it cover both private and public as well?
Yes, service providers are based on the understanding that both private and public will be covered.
Okay. So after you have done all your assessment, you just choose the service provider.
I think the mic went off. Yep.
Is there any liability for you in case, anything happens after that?
Sorry, repeat the question, you cut off.
Like example, you have done an assessment and you have refer, like you said, that can you please you tell your service provider that look, can you please provide all the necessary assistance to this patient for treatment? Now, in case somewhere along the line, due to whatever circumstances, the patient is unable to sort of fulfill the payment. So, are you subject to any liability?
No.
In that way?
No, we are not. Because we are a TPA, our job ends with the assessment. So the actual, after we've done the assessment, we've given the results, that's the end of our side of things. Right? After that, it goes back to the service provider, and any misconduct or any problems with payments on the patient side is dealt between the service provider and the patient. We do not include ourselves in that. Yeah? Okay. Yes. Sorry, she behind us here. Go ahead.
Are you working together with PKM setting, like their what social welfare department in every hospital?
Okay, so we have not reached that side yet. However, like I said, we are dependent on our service providers because we are a TPA, right? So we need to, when we reach that area, we want to make sure that the most commonly used drugs in immunotherapy, hormonal therapy, and targeted therapy are covered. So we don't want to go there and then not be able to help the patients, or help only for a certain drug and not for the other drug. But of course, that is an area we are looking into. It is just a matter of timing and a matter of covering our bases with our service providers. Yes. Sir?
Doctor, is this only available for conventional treatment or both for non-conventional?
Okay, so in the cancer landscape, when we say conventional treatment, we mean chemotherapy and radiotherapy. So we do not cover for conventional treatment, we cover only for non-conventional treatment, which is immunotherapy, targeted therapy, and hormonal therapy.
TCM and all that?
TCM, no sir, we do not cover for TCM. Yes sir, sorry, behind us, yeah? Yes.
Doktor, let's say kalau pesakit biasanya datang daripada government hospital, they do not, government hospital do not really subscribe to targeted therapy or immuno or hormonal therapy. So, tapi the patients wants to continue for treatment. Nak pindahkan dia ke private, itu bawah proses saja. Can it be done under the scheme, the program?
No sir, to move them to private is based on patients' discretion and also the advice from your HCP from the patient's doctor.
That means they need referral and so on to move.
Yes.
And daripada private bagi proposal untuk dia punya ubat ni targeted ke immuno kan?
Yes.
Baru boleh masuk.
So they need okay. So from government to go to private, discretion of patient and doctor, both of them agree. They are referred to the private healthcare organization. At the private healthcare organization, they also agree that this is the best way forward in terms of what drug you're going to take and all those things, your scheme and all that, and then they will enroll you into the program. Yep. Yep. Yes, sir.
As of how many lucky person has received the such a aid in total?
As of today?
Yes, as of today.
Okay. I cannot give you an exact number, but I can tell you that of all who have undergone the assessment, we have about a 95% rating of eligibility. The other 5%, like I said, is due to already having large amount of savings or having a high amount of monthly income already as it is. Yep. Yes.
How long is the approval process?
How long is the approval process? Okay. So what we do is we will, number one, we have to check with the service provider that you're actually registered under them. Okay, to obtain the drug, right? After that, we will contact you back again. We will give you a list of documentation the list just now, but even more sometimes. So depending on your situation lah. So we will give you the documents, and once you have collected the documents, send it back to us. Approval process, the assessment and the approval process, if you are approved, takes nothing more than 3 days, 3 working days. Yep. Any other questions?
It does, maybe between the lines, it just sounds like some of your providers are from drug manufacturers or drug pharma.
Again, can't disclose.
Guessing.
Okay. Yes. If you make the deduction, it didn't come from my mouth. Okay. Anybody else? Any other questions? Yes? No? No? Yes? Okay. Wonderful. Thank you everyone. Have a good day.
Thanks guys.